This is video number 3 on the circulatory system. This is the slide we left off on. When you have hypertension, again, you want to monitor the patient and certainly take their blood pressure before you give them any blood pressure medications. You want to educate the patient on side effects, dizziness, rebound hypertension if they stop their medication, electrolyte imbalances, especially potassium issues with loop diuretics, erectile dysfunction can happen depending on the medication they're on, especially beta blockers. There are complications of hypertension if it's left untreated: coronary artery disease, arterial sclerosis, heart attacks, heart failure, strokes, kidney or eye damage, almost always, and then left ventricular hypertrophy can happen. So when you have hypertension, there's a whole bunch of things that happen, but here are some nursing diagnoses: decreased cardiac output, activity intolerance, pain, self-care deficits, knowledge deficits, disturbed body image, risk for injury. You can think of a lot more. And I highly suggest that you create some concept maps using these nursing diagnoses, and we might be doing some of this in class just to solidify your understanding of each disease process. Next, after hypertension, we have arteriosclerosis and atherosclerosis. And arteriosclerosis is a thickening, loss of elasticity, calcification of the arterial walls. Almost all old people have some amount of arteriosclerosis, and hypertension and diabetes can make it harder. So when I think to determine the two differences of the words arteriosclerosis versus atherosclerosis, arteriosclerosis has to do with the biology of the artery itself. Okay, so that's kind of how we remember it. And atherosclerosis has to do with plaque that grows inside of the artery. And I think atherosclerosis is just a yucky word, and plaque is just yucky stuff. So that is a really silly, silly way to remember it, but that's how I remember it. And like I said, artery has to do with the function of the artery itself. Atherosclerosis is just yucky, as is plaque. Again, just like hypertension, there are non-modifiable and modifiable risk factors involved. Heredity, ethnicity, African American population are at far higher risk for hypertension as well as ather or arterial sclerosis. Men higher, and modifiable things that you can change: smoking, hypertension. Again, you see a pattern here. Almost every disease process, modifiable risks are always smoking, hypertension, elevated cholesterol, diabetes, obesity. And you start with obesity and smoking and move your way down. Coronary artery disease is the next one. And coronary artery disease has to do with blood flow to the coronary arteries themselves. The coronary muscle, the heart muscle, needs a lot of blood supply, and coronary artery disease usually is from atherosclerosis. So plaques develop in those arteries, and that's what causes an MI. Blood flow's reduced, chest pain happens, sometimes MI, sudden death, if it's not restored, can happen. Again, these are just a very quick overview of these disease processes, but you're going to see them, and I'm sure you already are seeing them in the clinical setting. Let's look at non-modifiable and modifiable risk factors. Age, ethnicity, African American again, gender, male, genetics, hyperlipidemia. Some people genetically have high cholesterol. And let's look at our modifiable risk factors. Look, the same ones are coming up: obesity, tobacco use, diabetes, hypertension. Now, when you have diabetes, is it modifiable? Depends. If you're type 1 diabetic, no, but controlling your blood sugar is. Hypertension, do you have it? Yes. Is it modifiable? Yes, because if you take your medicines, you can keep it within a normal limit. Elevated cholesterol, for the most part, you can control your cholesterol with diet. So these kind of things can be modifiable even if they are a disease process. Signs and symptoms of coronary artery disease starts usually with angina or angina, whichever way you want to sound it. It's the same word. And this is chest pain, and it's chest pain that is usually relieved with rest. Heaviness or tightness in the chest, sometimes pain down one or both arms. But the biggest thing you want to know about angina is it's almost always relieved with rest. Now, if someone's in the middle of an MI, it doesn't go away. Atypical angina is heartburn, shortness of breath, fatigue, some nausea, less severe pain. Sometimes the teeth hurt. Women tend to have atypical angina, and they also tend to ignore their symptoms. So women die from myocardial infarctions far more often than men do because they ignore them and wait too long to seek medical care. So when you're diagnosing coronary artery disease, they're going to look at cholesterol levels. Remember, LDL is the bad cholesterol. It's lethal. HDL is healthy. We're going to look at C-reactive protein, which looks for any kind of inflammation. We're going to check blood glucose levels, EKG, stress tests. Sometimes they'll do a CT or an MRI of the heart to look for any plaques that may be developing. What are we going to do to treat it? Obviously, we want to change any modifiable risk factor that we can so that we can decrease the propensity for there to be a problem. The first thing they do with someone with coronary artery disease is they put them on a baby aspirin every day. They also put people on baby aspirin every day if they've had a valve replacement, if they've had any kind of cardiac issue. They'll also use statins, and statins would be another good med for you to do a med template on, and those are used to reduce LDL cholesterol. We'll use vasodilators. Nitroglycerin is the main nitrate that they use. Calcium channel blockers encourage the cardiac contractility and make the heart beat more efficiently, so there's less work for the heart. Beta blockers open up the blood vessels, and then ACE inhibitors also help. Again, if any of these weren't on the current slides previously, make sure that you make a template for them because you'll use it recurrently. Okay, peripheral vascular disease, next issue. Peripheral vascular disease results from atherosclerosis that usually occurs in the arteries of the lower extremities, and arterial sclerosis can cause it too. It's characterized by inadequate blood flow. Tissue damage occurs below where the obstruction is or where the arterial sclerosis is. Arterial sclerosis is caused by a thickening of the arteries, and it ultimately results in progressive narrowing of the vessel lumen. Plaques may form on the walls, and again, that's arterial sclerosis. So what are some risk factors for peripheral vascular disease? Look, they're the same. Hypertension, hyperlipidemia, diabetes, cigarette smoking, obesity, sedentary lifestyles, a familial predisposition, and your age. You are, again, with cardiac, any circulatory issue, the modifiable, non-modifiable risk factors are pretty much going to be the same. PVD doesn't have a lot of symptoms except when it starts to advance. You can have this symptom called intermittent claudication, and that is when, say, you're walking to your mailbox and your lower legs start to cramp up. And then when you sit down, the cramping goes away. That's intermittent claudication, and that can happen. It's sort of like angina of the legs, and we'll talk about that a little bit more in class, but just remember it's oxygenation that's not getting where it's supposed to get, and so the muscles cramp up. When you run, your muscles will cramp up if you're not breathing, if you're not hydrated properly. So it's the same thing, it's just on a person who's not extremely exercising. But PVD in general will show itself if it gets bad. That intermittent claudication will become permanent. Skin color changes happen. They'll have like a reddish or purplish or cyanotic look. Eventually they become cool to the touch. The skin starts to mottle or turn color. And because the blood vessels aren't getting properly fed, hair loss will ensue. This is a pretty good visual of what happens if there is an arterial issue and if there's a venous issue. The two are completely different. So if there's an arterial issue, you have to be very careful. That can become an emergency very quickly, especially if somebody has absent pulses. If you have an absent pedal pulse, your foot's not getting fed, you could lose your toes or your feet. This happens a lot in advanced cases of kidney disease and diabetes. Venous manifestations are a little bit different. The patient will have normal pulses. Their skin may turn brown. They'll have a lot more edema. Sometimes they'll get venous stasis ulcers, dependent cyanosis, pain, when their legs are dependent, but when they're elevated, it goes away. And these patients will have very normal toenails. Arterial, they won't because there's no oxygenated blood flow. And here's some pictures, and I like this little diagram here because it tells you what happens if there's arterial disease and what happens if there's venous disease. Arterial disease is far more serious and has to be treated. Venous disease we treat symptomatically. To diagnose PVD, they use arteriography, which they basically do sonograms of the veins and the arteries. They do an exercise tolerance test to see if there's any claudication. Then they do, and I always have trouble pronouncing this word, plethysmography, which basically is using some dyes, looking deeply at the veins and the arteries to see where there's any kind of obstruction. They might do systolic blood pressure measurements on the legs, ultrasounds, again, MRIs and CTs, depending on what's going on with the vessels. First treatment is healthy diet. Second is drugs, aspirin, Plavix. Those medications are anticoagulants, and they have to do with platelet aggregation, so they make the blood more slippery, is what they basically do. Sometimes they have to do different surgeries. Sometimes they'll stent the leg, sometimes they'll bypass an artery in the leg, just like they would do in the heart, to feed the muscles in the lower extremities. Risk factors. Now we have the same risk factors for PVD sort of as we do for DVT. Now we're going to start talking about that. DVT is deep vein thrombosis, and first of all, the biggest risk is probably a surgical procedure. Now, if you have hip, leg, anything like that, that makes the surgical complication worse because that leg is immobile. But you can get a DVT for a lot of reasons. And anytime your body gets the signal that it needs to coagulate, you have a chance for a DVT because it's a blood clot in one of the deep veins, usually in the legs, but it can occur in the arms or other places, but it's almost always in the lower legs. If you have chronic heart failure, and your blood is viscous, so it's thicker anyway, you're more at risk for clots. If you're immobile for any reason other than surgery, you're at higher risk. Pregnancy, your body's preparing to deliver a baby, preparing to deliver a placenta, so the clotting factors are higher. If you take birth control pills, with smoking, it's even worse. Signs and symptoms are calf or groin pain, depending on where the DVT is, and it's pretty significant pain that does not go away with movement. Sudden or unilateral swelling of the affected area is also very common. And at that point, I'm going to stop this one. This is video number 3, and then we'll move on to video number 4.